Good afternoon, dear patient, dear friend, dear colleague. Now, today we will have the next video on education in endometriosis. Sorry, my last video was for several weeks ago because we had the ISON meeting in Istanbul for several weeks. Sorry, and believe me, it was great. We had a lot of young colleagues who want to learn neuropelveology, and that made me really happy. So today we will talk about um, something a little bit tricky. So endometriosis, 30 years of research, progress and stagnation. I want to talk today more a little bit about stagnation than progress because it's a little bit strange. Um, you know, I start my career as a cardiovascular surgeon, then I'm an oncologist, and I'm very lucky because I got the education and the training for 30 years in oncology and in endometriosis together. And that is something very important, I think you will see later on in my lecture. And now I'm going a little bit less of international congress in endometriosis, um, because I have to spend more time with my patient in Zurich, but also because I have the feeling I learn less. I have the feeling that over the last 20, 30 years, we are talking always the same. When I'm going on Congress on endometriosis, hormonal treatment on one side, is endometriosis rectum surgery with a debate between shaving and bowel resection, discoid resection, is more or less always the same over the last 20, 30 years. And of course, we introduced the robotic surgery, but new insight in endometriosis, where the endometriosis is coming, new revision, breakthrough treatment or diagnosis, I'm missing that. So my introduction. Endometriosis, I think that is clear for everybody, that is a condition that affect a lot of patients over the world and can affect not only the pelvis, but even more the bowel, the diaphragm, and very, very seldom form of endometriosis outside the abdominal cavity, like pulmonary endometriosis. Of course, we want the awareness and the knowledge over the last 20, 30 years that we're not talking only from endometriosis, but we are talking from endometriosis within the uterus, what we call adenomyosis. We're talking from peritoneal endometriosis, endometriosis genitalis externa, and we're talking from deep infiltrating endometriosis, which is a kind of benign tumor in the pelvis that can infiltrate and destroy it, surrounding uterus, surrounding from the cervix, mean in the front the bladder, back dorsally the rectum, and laterally it can involve the ureter, and it can involve even the much more lateral part of the pelvic cavity, the pelvic side nerve, and the sciatic nerve. It's clear that endometriosis, the main syndrome, is pain, visceral pain. That means pain in the lower abdomen in combination with a lot of vegetative symptoms like pallor in face, dry lips, fatigue, all these symptoms, bloating abdomen. I talked about that previously in another lecture. Of course, because the pelvic nerves, which brings the information of pain to the brain in endometriosis, are the same more or less for the bladder, for the uterus, the genital organ, and for the rectum. Of course, patients with endometriosis will always experience during men's bleeding not only pain, but also issue with the bladder, like feeling to have an affection, once again, every month an infection, probably not every month an infection, but every month you have an irritation of the pelvic of the nerves. Some patients have a bladder endometriosis, of course. The rectum is the same with bloating, constipation, and during the men's bleeding, alternance between diarrhea and constipation. Infertility, probably in the one of my next lecture will focus on endometriosis and fertility. Endometriosis is not a reason in most cases for sterility. Sterility means patient have no chance to get pregnant. Infertility is not that hard, and to say endometriosis is always a reason to not get a baby, and for that you have to go to IVF, that is a wrong message. Definitively, we know that 30% maybe of the patient will get difficulty to get pregnant, but to say endometriosis is a clear cause to not get pregnant, no, I cannot accept this statement. So, what will improve in the last 30 years? The recognition and the awareness. Yes, definitively awareness, not just in the medical community, but also in patient community. Awareness, I remember for 25 years, one day I had a lecture in Berlin, and I was talking about deeply infiltrating endometriosis of the vagina with rectum involvement. And I remember it was probably 1994. At that time, I was in the University of Vienna, and I performed the first rectum resection by laparoscopy for endometriosis in Europe in 1994, 1995. And I remember first, for everybody, I was a bad man killing the patient because I performed bowel resection. In between, the situation changed a lot. Today is eventually even more contrary. If I go on Congress, some colleagues are fighting who is doing the most bowel resection per year, and that is a little bit crazy. But it is like that. So we want this awareness that endometriosis is not just a disease that in painfully, but endometriosis can affect bowel, bladder, and all these things. Endometriosis can be very demanding and can require a very, very difficult and huge surgery. I remember also that this patient, during this congress, one of the colleagues asked me, "But Mr. Possover, how are you doing the diagnosis of such an endometriosis?" At that time, we had sonography. We were not trained to send all patients by suspicion of endometriosis to MRI. And by the way, I'm still not doing that. I'm pro-vaginal examination, pro-vaginal sonography, and pro-sonography on the kidney. And I send my patient to MRI just in special case. So in any case, this colleague asked me, "How are you doing the diagnosis?" At that time, I was standing in front of the auditorium of the colleague, and I didn't understand the question, because for me it was obvious. If I do a vaginal examination and I see a black nodule behind the cervix from 2-3 centimeters, and when I put my finger in the vagina, I feel a 2-3 centimeters nodule that involves the vagina, the diagnosis is clear. You have to be blind to not see such kind of endometriosis. So the awareness that this pathology may exist will increase, but you will see in the rest of this lecture, make me sad, because at that time, patient require more or less 10 years, 12 years to get the diagnosis and the proper required treatment. And unfortunately, I think in the last 30 years, the situation didn't really change. Of course, we improve the diagnosis with imaging, MRI, but once again, I'm pro sonography. I know that in a lot of countries, for example, in the United States, vaginal sonography, kidney sonography have to be performed by radiologists, not by gynecologists. So probably they are more sending patients for MRI, but with a finger for feeling the endometriosis around the cervix. with a vaginal sonography to see adenomyosis, to see the blood supply of the uterus, to see pelvic congestion syndrome, to see if a nodule is infiltrating the bladder, or to see if a nodule is infiltrating the rectum, to see if I have a dilation of the kidney. All this information I can get during one consultation by my own. So I'm a pro management of the patient all in one. So when a patient come in my office, I want to have the diagnosis. And of course, it takes time. It cannot be a consultation from 10 minutes, 50 minutes. It will take 30 minutes to 1 hour. But at the end of my consultation, I will have a clear diagnosis and I will know that, okay, I have to do surgery or not. And that is important because if I come back to adenomyosis, peritoneal endometriosis, and deeply infiltrating endometriosis, treatment is not the same. If you ask me to remove surgically adenomyosis, oh, in most of the case, I will not be able to do that. Of course, I can cut part and resect part of the uterus, but to say I'm able to remove adenomyosis like I can remove a myoma from the uterus, no. So in most cases of adenomyosis, better to not perform a surgery. And in peritoneal endometrium, in some cases, we have to do the surgery. In some cases, I believe there is no need for surgery, depending from the patient. So the indication for surgery in endometriosis patient is not the disease, but the patient, depending from her age, depending from her wish. A patient with a bowel endometriosis without stenosis, with 25, I will perform the surgery. But if the patient is 45 or 48, close to the postmenopause, better to not touch this disease because an endometriosis of the rectum take 10 years more or less to develop to a diameter of 3 centimeters. So patient 48 with an endometriosis of the rectum without any stenosis of the rectum, why to do the surgery? In few years, the patient will become more postmenopausal and that it will be no need to do probably any kind of surgery. So clinical diagnosis, yes, improve, but still in a lot of practice, gynecologists are still not doing the right diagnosis, even if in most of the case of deep endometriosis, you need only your fingers. And how many times I heard, yeah, my gynecologist told me, yeah, you have probably endometriosis, but if I send you to a hospital that will do a big surgery, it's a dangerous surgery, maybe you will get a colostoma and all this stuff. So better to wait and see. I cannot support this position because if the patient have a small endometriosis which don't require bowel resection, why to wait until we'll need a bowel resection? Better to perform the surgery in an early stage. The surgery will be much less complicated with much less risk of complication. Of course, with laparoscopy, we were able to increase the radicality of the surgery. Now we have the introduction of the robotic surgery. I'm not against robotic surgery, but I'm pro that gynecologists are not losing the skill. What I mean that the first route for surgery in gynecology was the vaginal surgery. And for example, when you have a big nodule inside the vagina, I remember the beautiful video from David Redwine. He resects this nodule vaginally because it's much more easier. Now, if you're only trained in robotic, you will miss the vaginal surgery, the vaginal ability to perform a surgery. So I'm not against robotic. I'm not against vaginal. I'm not against open surgery and against laparoscopy. I am the kind of surgeon who believes that as a gynecologist, to be able to manage all kind of surgical situation, you have to be trained in open surgery, in vaginal surgery, in laparoscopy surgery, and in robotic surgery. You have to be trained in all these kind of surgical approach. It's not a question of philosophy. I'm a robotic or on laparoscopic surgery or vaginal surgery. No, we have to be a pelvic surgeon. So, of course, we have development of interdisciplinary endometriosis center, which is a good thing. If I see, for example, in Aarhus, in the endometriosis center, you will find only colleagues who have a high level in diagnosis and surgical treatment. And I think it's good that not everyone try to do surgery. And that is probably one of the main issue, because when patient is living somewhere in a country with a small hospital, and the next interdisciplinary endometriosis center is 300 kilometers away, probably she will go with the hospital in her own hospital close to her home. And if they are not high level skilled surgeon in endometriosis, probably in a lot of patients, they will do bipolar coagulation or partial resection. And then that is one of the points when we say, oh, endometriosis surgery make no sense because patient will always get a recurrence. I don't agree. If the patient will develop a recurrence or not depend also from the surgeon. So the less you are skilled, the more the risk not only of recurrence, but of persistent. Persistent means not all the endometriosis have been removed. And that is a little bit an issue now, because I see more and more patients coming in my office with a previous surgery for several months or 1 year, and with recurrence of pain. And when I see the surgical report, I found, oh, we found an endometrioma during the surgery, but because of the eggs reserve, we didn't want to remove the ovarian cyst. And we found some endometriosis in the peritoneal cavity because the patient had further desired pregnancy, we didn't touch this endometriosis in order to avoid adhesion, which could reduce the chance to get pregnant. And then I think, wow, I don't understand that, because colleagues are doing a surgery, and during the surgery they decide to not touch the endometriosis. For that, you don't need a surgery. If you believe that you have not to remove an ovarian cyst and you will not remove endometriosis of the pelvic cavity because of the risk of adhesion, why are you doing the surgery? I don't understand that. So now stagnation and still lacking. Still lacking clear understanding of etiology. We still don't know where endometriosis is coming from. We have theory, but a clear answer at the cause, we don't have. So on this point, over the last 30 years, we didn't make any step forwards. And that is a problem because, in medicine, you have always two kinds of surgery. You have symptom treatment and you have cause treatment. And of course, for example, hormonal treatment in endometriosis are just symptom treatment. You induce with the hormonal treatment a deactivation of the endometrium, but when you stop the hormonal treatment, the endometriosis will go up and will grow further. So it would be nice to have a causal treatment to treat the cause of the endometriosis. So we don't have such kind of option today. Research finding remains low comparing to other chronic disease. It is a fact. And there is another problem. There is no funds for education. And that is really a problem, because suppose now there is a young guy sitting in somewhere in the middle of, I don't know, of Australia, for example, and this guy would want to become a specialist in endometriosis of the sciatic nerve. Okay, he look on internet and will find also the guy with the most greatest experience in endometriosis. The sciatic nerve is located in Zurich. Is Mr. Possover. Oh, I would like to go there to him and to win some knowledge, to be trained by Possover. That means I have to go there for example, 3 months or 6 months. That means I will have to quit my job because my hospital probably will not accept that I'm going abroad for 6 months. My hospital will not give us my salary. So suppose I have a family, kids, I cannot go to Zurich. It's so simple like that. And when I will be in Zurich, the city of Zurich is very expensive. So I will have to pay my food, B&B, my hotel, my room, and all these things. So for a young guy to come to me mean a lot of financial efforts. And today, there is no fund for that. I remember that for 2, 3 years, we had a meeting with a foundation, and this foundation mentioned, oh, we got a lot of money, million of money, of dollar from by the foundation. Where we have to invest this money. So this the money was invest in awareness, in education of patient, in research. But we were 2, 3 surgeons who said, try to invest a little bit from this money for education of young colleagues. And we didn't get any answer. And this never happened. So, delayed diagnosis remain common. I will come back. It's exactly what I mentioned. We were not able over the last 30 years to change anything to this situation. So the science in endometriosis has moved definitively, but not fast enough. So now the surgery. Yeah, surgery remains the most effective treatment for deep infiltrating endometriosis, for sure, because it's a tumor. You can take as much, as long hormonal treatment you want, the deep infiltrating endometriosis will not disappear. And on the day you will say, oh, I would like to get pregnant, you have to stop the hormonal treatment because there is no hormonal treatment today where you can treat the endometriosis and become pregnant at the same time. Surgery is also the most effective treatment for refractory endometriosis. And the goal is to the complete, if we can do that, excision, resection of the lesion while preserving the fertility, to remove an ovarian, to say, wow, it was a big endometrioma. Nobody is able to remove such kind of endometrioma. Sorry, I have to remove the ovarian. I cannot accept like that. In endometriosis, there is never need to remove an ovarian. Then I would prefer to say to the colleague, learn first how to do surgery before removal an ovarian for endometriosis. And of course, you have to preserve the organ function. And that is my last lecture when I was talking about nerve sparing technique. You cannot go like a bulldozer in the pelvis and cut everything. And then the patient have a destroyed pelvic nerve. It's one of the worst what can happen that a 30 years woman have to empty the bladder with a catheter. So today is not acceptable simply to say, I cut, and I don't care on the nerve. So, resection versus coagulation. So, coagulation means burning. Bipolar coagulation, burning of endometriosis is faster. Of course, it's much less invasive, and you can do that in outpatient sector. Resection is more tricky in outpatient sector because of medical legal issues. The responsibility, at least in Switzerland, the responsibility of the surgeon is the same if the patient is in out or inpatient sector. So no any surgeon will be stupid enough to perform a big endometrial surgery and to let the patient 2 hours later going home. If the patient have a bleeding home, that is a responsibility of the surgeon. So you can only perform proper endometrial surgery in hospital stay and for the surgery enough time to do that. So coagulation, of course, have a higher recurrence risk. And of course, if suppose you're not trained in what we call retroperitoneal surgery, you can induce terminal damage to the surrounding tissue, for example, the ureter, or for example, when you coagulate endometriosis of the bladder, you can have lesion of the bladder wall. On the other side, you have the resection, which mean a precise removal with scissors or whatever of the lesion. The resection have definitively a lower recurrence and better histological assessment. Better, by the way, the only one, because you have to keep in mind that the diagnosis of endometriosis in histological one. So I have to take some tissue out of the body and to give the pathologist, and under the microscope, he will be able to say, yes, it is endometriosis or not. That means when I see a report of radiologists who said, yes, patient have an endometriosis of the rectum and an endometriosis of that and that, I'm always wondering how he can say that, because a radiologist is interpreted only in picture. So he can say suspicion of an endometriosis of the rectum, but to say it is an endometriosis, I think it's not allowed for a radiologist to say that. Only the pathologist can say that. So resection is technical demanding. So if you perform a resection of the pelvic peritoneum, you have to expose the ureter. Maybe you will have to expose the bladder. Definitively is much more demanding, mean you need more education. So there is there is no clear consensus if the restricted resection or extensive resection is the key. The difference is between both. You have a surgeon, he don't want to make coagulation, he don't want to perform resection, and I am definitively a resection surgeon, not a coagulation surgeon. I don't believe in bipolar coagulation or lesion. I want to resect the lesion. So in restricted resection, you remove only what you see during the surgery. So you will preserve much more tissue around. And of course, your surgery will be much less invasive. That means lower operative risk, less risk for postoperative or intraoperative bleeding, less risk for lesion of the nerve or the ureter. But you may leave microscopic or lesion behind the peritoneum. And that is then, if the patient develop a new endometriosis again, by the way, it's not a new endometriosis, it's not a recurrence, it's a persistence. So extensive resection, full pelvic peritoneumectomy. And that is something I see more and more when I see patients coming in my office with pain or persistent pain. I see more and more video from colleagues who are performing a pelvic peritoneumectomy. And sometimes I'm sitting in front of my computer, I see that and I say, wow, he's removing the whole peritoneum of the pelvis. So he's doing really a big surgery. But at the beginning, I saw only a small spot of endometrium on the left, on the right. And there I have always a feeling that is too much. So it could be reduce the long-term recurrence, but once again, there is no consensus. And then I'm coming back to my formation. I'm an oncologist and an endometrial surgeon. Oncologist who has exactly the same problem. When you perform a surgery, for example, cervical cancer, nobody knows if you will be able macroscopically, you will remove everything. Of course, surgery are well standardized. But if you will miss some tumor cell on the left and the right, nobody know. But you cannot remove all the pelvis for a cervical cancer. That is what we call an exenteration. We saw exactly the same with the breast. For 30 years, 40 years, breast cancer were treated by general surgeon. And general surgeons at that time always remove the whole breast. And then we gynecologists, we start to remove only the tumor. And of course, if you're too close to the tumor and you left tumor cell or tumor, the recurrence is programmed. The patient will get a recurrence. So in oncology, we say you have to remove the resection of the disease with margin free. Margin free mean 1.5 centimeters. And then the pathologist will tell us, yes, where you cut around, there is no cell. No cell mean no million of cells. But even a pathologist with good eyes will miss single cells left on the right. So in oncology, we found a consensus. We cannot always perform an exenteration, remove everything in the pelvis. In my opinion, in endometriosis, is exactly the same. You have to be able to make the choice between vaginal surgery, open surgery in endometriosis. When I'm honest, I didn't perform any open surgery over the last 30 years for endometriosis. But in case of complication, you have to be able to open the abdomen. Robotic surgery, laparoscopic surgery. So I want to have the choice in my hand to use the adapted, the proper instrument for my patient. I want to be able to have a personalized surgery for the patient. And for the restricted or extensive, it's exactly the same. In a patient 25, I will be probably less extensive. I will try to avoid a full peritonectomy if it's no need, because such a full pelvic peritoneectomy will induce adhesion. And this 25 years woman want to get pregnant. So if I remove all the peritoneum from the pelvis, I will maybe reduce the risk of recurrence, but I will have a bad impact on the fertility of the patient. Now, if I have a patient, she's 45, and she's taking hormonal treatment, then I will be more radical in terms of removal of the peritoneum because the patient have no desired pregnancy. And once with 45, the patient don't want to get a recurrence in few months later. So I think you have to be you have to think during the surgery, to not be part or to not belong to a school. I'm the school of restricted, I'm school of extensive. No, you have to adapt to the need of the patient, to what you found during the surgery. The limit of the pathology. And that is an issue also. Once again, only the pathologist will be able to confirm endometriosis, yes or not. And the pathologist will have to exclude malignancy. But the pathologist today does not quantify the degree of infiltration. And that is an issue because when I see a patient underwent a full pelvic peritoneectomy, so the colleague remove 10 centimeters time 10 centimeter tissue, and then when I see the histology and I see, wow, the pathology describe say yes, endometriosis. Everything and everybody is happy. We perform a good job. Yes, you have confirmation it was endometriosis. Like it did a good job. But if you read the pathology, you will see it was only few millimeters on endometriosis. So for me, it's too much. So we have I'm missing the information from the pathologist who tell me, yes, Mr. Possover, you had removal 10 centimeters and the endometriosis affect 80%, 90% of the disease of the specimen, or less than 5 centimeters. Because if the pathologist said less than 5 centimeters, I would say the surgery was too radical, too extensive. While if I remove a piece with 80%, then probably I made a good job. So microscopic lesion can be easily missed. Yes, but even if you perform a radical surgery. Think about that the man's bleeding on inside the pelvic cavity and in the abdominal cavity. So to say with a knife, I have to be able to remove even every single cells. We will never be able to achieve that. So I think pathologists would have in the future not to tell us just, yes, I confirm it was endometriosis or not, but also in percentage, how many percentage of the specimen were really involved by endometriosis. The second problem is the training of the surgeon. And we have to accept, even if we don't want to talk about that, to hear that, but we have a motivation crisis. Because endometrial surgery is challenging. It's not a small surgery. It's more or less an oncological surgery, but in young patients with desired pregnancy in the future. So it's even more challenging than oncologic surgery. It's time consuming, and not just during the surgery, but before and after. Before for the diagnosis, after because you have to take care on your patient. And suppose you have a bleeding, you will have to stay up at 3 o'clock in the night and to care on your patient, to perform the revision surgery. So it's very time consuming with a high responsibility and medical legal risk. The more you will do in surgery, the more you will be exposed for medical legal risk. And that is really an issue as a patient think about. Yesterday, a surgeon performed a surgery. He tried to do his best. And then he got a lesion of the ureter, lesion of the rectum, or even he didn't get a lesion. He performed bowel resection or discoid resection, and the patient got an anastomose leakage. Big complication with pelvoperitonitis. Patient then go to a lawyer. Then do you think that when a young doctor got medical legal issue because he tried to do his best, he will be in the future still able to do the best? So that is a question also of the responsibility of patient. And endometrial surgery, like oncological surgery, is mentally and emotionally demanding. It's not we are doing the surgery, then we are going home and we left the patient, the surgery in the hospital. We are bringing all this thing home. When we had a difficult surgery and maybe a complication, believe me, we are not happy at home. And it will affect our family as well. So mentally and emotionally is really demanding, and that explains that some surgeons after a while stop to do large and big surgery because of all these aspects. The aspect of burnout and poor work-life balance. If I think my life, when I was a cardiovascular surgeon, I was on duty 1 week. I was sleeping 1 hour per 24 hours. And today, as a private doctor or when I was a chef, of course, there are some rules that doctors have just to work so many hours per day. But when you're a chef or when you're working on your own, nobody cares on that. If suppose I perform all my day in the ward yesterday and in the night, and the day after I have still surgery, nobody will care on that. So many experienced surgeons, and that is the problem, and that will be my problem as well. We are boomer. So we are 60, around 60, a little bit less, a little bit more, and we will get retired very soon. And that is really a problem because the boomer are building the biggest part of the surgeon for today. So future risk, surgeon shortage, especially for high complexity case. When people like me with 30, 40 years of experience will get retired, part of the knowledge we got over these last 30, 40 years will get retired with us. Future risk, high medical cost, and interdisciplinary team. Why? Because I will come later, maybe on interdisciplinary team. So physician knowledge and training, limited knowledge. A survey on general practitioner in New Zealand shows that 52% of the GP said to have insufficient knowledge, and just 35% had read the national guideline of diagnosis and management for endometriosis. And in a United States study, only 11% of surveillance healthcare providers correctly identified the prevalence of endo. So I'm coming back to the delay in diagnosis. There are clear study who shows that the delay, there is a delay of 3.7 years between the symptom onset and the first presentation to the physician, and further, more or less 6 years from this first presentation to diagnosis and treatment. That means, once again, over the last 30 years, we were not able to change anything to this diagnostic delay. And then we have another problem because in a Finnish national wide course study from 1997 to 2012, this study shows that we are doing less and less surgery in endometriosis. We are doing more and more coagulation, less and less surgery, more and more IVF, more and more hormonal treatment. So the incidence of recurrence will definitely increase. And you know that as a gynecologist, we are really proud. When we are going on the Congress, some colleagues are fighting how to do shaving discoid. Yes, it's good. And one is coming with a cohort of 300 patients, the other one 200 patients. We are proud, of course, to show our data. But the truth is, it's a shame. Because think about endometriosis of the bowel take 10 years to grow and to start to develop a rectum stenosis. That means when we are doing a bowel resection, it's because 10 years more or less, we were not able to react and to say, oh, you have endometriosis of the rectum, let's perform the surgery in an early stage. And that is incredible because if we see the data coming from the general surgeon, I read because there is a paper from the American College of Surgeons National Surgical Quality Improvement Program, who shows that between 2005 and 2015, the incidence of colorectal surgery in endometriosis even increased. That means we are even making not only too late, but less and less diagnosis on endometriosis of the rectum. So if as a gynecologist we would do our job, normally we would not have to perform bowel resection at all because we have 10 years time to react. Think about that. So in many centers, in many countries, there are center specialized or certified endometriosis center. And that is a little bit problem. I was certified in the past. And once for several years, when I have to be recertified, colleague came in my office and said, oh, but Mr. Possover, you have notified enough case for recertification. And I said, yeah, but guy, look, I'm in a high specialized center. I'm doing all the surgery by my own. I don't have a team of 15 colleagues around me. I am doing all the surgery by my own. And I had probably the highest level and more difficult kind of endometriosis with endometriosis, the pelvic nerve, and so on. And then said, yeah, but we have not the required number of procedure per years. And for this reason, didn't become the recertification. And that is a problem because certification are often based of infrastructure, multidisciplinary approach, and organizational quality. But surgeon skill and experience are not part of certification. And I remember that for more than 10 years, I had a talk with my big friend, Jörg Keckstein from Austria. And we were exactly talking about that. And we were talking, we said, now it's time to certify the surgeon because it's nice to come in a specialized center. It's nice if everything is beautiful in this center. But what the patient really want is to have the right surgeon to get the proper surgery. So the prognostic in endometriosis management is like in oncology, mainly depending from the surgeon, from the individual surgical skill of the surgeon. You cannot compare one surgeon with the other, with the next one. Every surgeon have an own surgical skill, a own surgical experience. And some my generation, I told you, I am a cardiovascular surgeon, oncologic and endometriosis. I will have another experience and capability, surgical capability, comparing to a surgeon who just learned gynecology and not oncology and not cardiovascular surgery and not neuropelveology. So there is an urgent need to certify individual surgical skill. We have to go in the OR and to see how the colleagues are doing the surgery. And of course, nobody or a lot of people don't want that, don't like that. But we will have to do that and we'll have to control if they are able to do pelvic surgery and neuropelveology. And just few centers I found in local press in Switzerland. I found in the Just Medical Journal a significant portion of the current gynecological surgical workforce is approaching retirement age. This impending wave of retirement raised concern about potential shortage in experienced surgical professional. And that is a reality. It will go in this direction. In the same journal, the introduction of the 41 plus 4 hours work week for surgical residents in Switzerland aims to improve work-life balance, yes, but may inadvertently reduce hand-on surgical training time. It is like that. My generation, we spend our life in the OR, in the hospital. It's even not allowed today for the doctor. Even if I have a high motivated young colleague who want to learn surgery, he cannot work more hours per day. He cannot work all the day and the night how he would like to do it because at some point he have to go home by law. Now in Springer, the combination of an aging workforce, shifting preferences among younger physicians, and change in training structure could lead to a shortage of qualified gynecological surgeons. This potential shortfall may impact the availability and quality of surgical care for conditions like endometriosis, which often require specialized surgical intervention. And that is an appeal to you, patient. You're going on the street for a fight for the awareness of endometriosis, awareness among patients, awareness among doctors, but you have to find for education and training on young doctor. Otherwise, in the future, you will come on the street and we said, yes, we have endometriosis, we need the right treatment, but there will be probably not enough doctor to treat all the patients with endometriosis. And that is really the reality. We, the boomer, will get retired in the coming few years. So, in conclusion, to address this challenge, strategic initiatives are needed, including enhancing the appeal of surgical specialties through flexible training and work arrangement. That means when a young colleague want to say, "I want to become a surgeon," we have to push him. We have to provide him the proper environment to become a surgeon, but also to have a normal life. Implementing mentorship program to transfer knowledge from retiring surgeon to younger colleague, to retiring surgeon like Jörg Eckstein. Like, I'm not retired, but I will be in the coming few years. So it will be my duty, for example, to go to Calcutta with young colleague and to teach, to train them, and at the same time to treat poor patient from Calcutta. That is my dream for my future. We have to invest time and money. It is costly to train a colleague. We have to invest money in training program that accommodate work-life balance while ensuring surgical proficiency. And we have to encourage policies that recognize and address the unique demand of surgical career. Proactive measures are essential to ensure the continued availability of skilled gynecological surgeons to meet future healthcare needs, especially in gynecology. So my final thought: every patient deserves the best possible care. That is clear, no discussion. And that means the best trained hand more than the best trained center. Let's invest in training, education of colleagues, and evidence and access for you to the best hand, not just in machine. What I mean, robotic and MRI and certification. What you need are high skilled hand with a good heart and a smart brain that make the quality of a surgeon. Thank you very much for your attention, and keep healthy. See you in 2 3 weeks with the next video. Thank you so much. Bye bye.